Hi and welcome to my lecture on polycystic ovary syndrome. To download my lecture deck, please go to my WordPress site, Docina Obigaine. References for this lecture include Comprehensive Gynecology 8th edition and a journal on polycystic ovary syndrome written by Yao et al. And here's the outline of my lecture. Polycystic ovary syndrome is the most common endocrine disorder among reproductive age women. It was first described in 1935 by Stein and Leventhal, and back in those days, this syndrome was described as consisting of amenorrhea, hirsutism, and obesity in association with enlarged polycystic ovaries. Now, the prevalence rate for PCOS depends on ethnicity. For Caucasians and South Asians, the prevalence rate is quite high at 15 to 20%, while for Southeast Asians, the prevalence rate is lower than these numbers. Many medical societies and institutions worldwide have tried to establish the criteria for the diagnosis of PCOS. The very first to have established a criteria for the diagnosis of PCOS was the National Institute of Child Health and Human Development back in 1990. And as you can see here, they gave two criteria for the diagnosis of PCOS, and that's menstrual irregularity and hyperandrogenism. Note that they did not include an ultrasound criterion for the diagnosis of PCOS. However, worldwide, what is the most accepted criteria for the diagnosis of PCOS would be this one, the Rotterdam criteria, which is established by two medical societies, that's ESHRE and ASRM, back in 2003. As we can see here, they set three criteria for the diagnosis of PCOS. We have menstrual irregularity, hyperandrogenism, and polycystic ovaries on ultrasound. Now, to diagnose PCOS, one must have two out of the three criteria. However, the caveat to this is that we have to exclude all other underlying hormonal disorders or tumors that might have the same manifestations as PCOS, and this includes the following. Now let's talk about each criterion of PCOS. So first, ovarian morphology, and this is classically defined as 12 or more peripherally oriented cystic structures about 2 to 9 millimeters in size in one sonographic plane in at least one ovary. An example of this would be this picture at the upper right-hand panel, where you see cystic structures that are peripherally located. That's why in the past we called this the rosary bead pattern. Okay, so with the advent of high-resolution ultrasound machines, experts now recommend a follicle number per ovary of at least 19 to 20 instead of the usual 12. Okay, and another valuable ultrasonographic parameter would be ovarian volume of more than 10 ml. Okay, an example of this would be this picture here on the right lower panel, where you see that the cystic structures are not anymore peripherally located, no? And cystic structures number about more than 19 or 20. Anti-Mullerian hormone greater than 4.7 nanograms per ml has been a useful surrogate marker of FNPO for the diagnosis of a polycystic ovary syndrome. However, it is not diagnostic or as valuable as ultrasound imaging. About 10 to 25% of the normal reproductive age population, that's meaning there's no symptoms or signs of PCOS, may have polycystic ovaries found on ultrasound. And these ovaries have been called polycystic appearing ovaries, or polycystic ovarian morphology, or simply polycystic ovaries. Now, the isolated finding of a polycystic ovary should not be confused with the diagnosis of PCOS. Remember, when you diagnose PCOS, the patient has to fulfill two out of the three criteria. So an isolated finding of a PAO or a PCOM should not be confused with the diagnosis of PCOS. But having PAO may be a risk factor for other features of PCOS, such as insulin resistance or cardiovascular risk factors. As I've already mentioned, not all women with isolated polycystic ovaries have PCOS. An ovary is polycystic in up to 20% of young girls, and thus the ovary transitions early in life from normal to polycystic appearing. This influence occurs in a specific way by genetic factors or environmental factors, or it is induced by other endocrine disturbances. The woman who develops PAO or PCOM may have normal menses, normal androgen levels, and normal ovulatory function and parity. Now, if this woman with PAO is subjected to various susceptibility factors or environmental factors or other challenges or insults with varying degrees of severity, then this woman with PAO may actually develop a full-blown syndrome of PCOS. Normal homeostatic factors may be able to ward off stressors or insults in some women who can go through life without PCOS but actually have PAO. These stressors, which include weight gain or psychological stress, may allow the symptoms of PCOS to emerge eventually. Another criterion for PCOS is menstrual irregularity, and this includes oligomenorrhea or frank amenorrhea. Irregular cycles signify problems with ovulation, and menstrual irregularity is the best correlate of insulin resistance among women with PCOS. The third criterion will be hyperandrogenism, and this includes symptoms of androgen excess such as hirsutism, acne, alopecia, and even seborrhea. Now, blood measurements of testosterone may not always be accurate and often are normal in women with symptoms of PCOS. The androgen excess has been implicated in contributing to abnormalities in LH secretion, weight gain, and adipose deposition, and the metabolic derangements of PCOS. 11 oxygenated androgens such as DHEAS or DHEA, which are derived principally from the adrenals, are quantitatively the most abundant androgens in women with PCOS, and this explains many of the symptoms and derangements in metabolism in a woman with PCOS. Adipose tissues also secrete androgen, and this intra-adipose androgen source seems to contribute to lipid abnormalities and insulin resistance in women with PCOS. Now, hirsutism among all hyperandrogenic signs and symptoms is touted to be the best biomarker for hyperandrogenism. And this is quantitative or objectively quantified according to the modified Ferriman Gallwey score. The severity of hirsutism, though, does not correlate well with the circulating androgen concentrations. Now, due to ethnic and genetic differences, hirsutism may be less prominent in some Asian populations, such as Southeast Asians or the East Asians, as compared to the Caucasians or the South Asian groups. And this is what we call the modified Ferriman Gallwey scoring. As you can see here, we have 9 body areas. Okay, so we have the upper lip, the chin, the chest, the upper abdomen area, the lower abdomen area, upper arms, thighs, upper back, and lower back. So for each body area, we score it from 1 to 4. Okay, so a total, the modified Ferriman Gallwey score will be the total for all 9 body areas. So a total of less than 6 to 8 will be normal. A total of 8 to 15 is mild hirsutism, and a total of more than 15 is moderate to severe hirsutism. Now we go to the different phenotypes or phases of PCOS. There are actually 4 different phenotypes of PCOS. We have type A, type B, type C, and type D. So the type A phenotype is actually those PCOS patients with all 3 criteria, meaning they have hyperandrogenism with chronic anovulation and polycystic ovaries. And sometimes we refer to these individuals as having the classic type of PCOS. For type B, these are the patients with hyperandrogenism and chronic anovulation or irregular menses, and this constitute the original definition under the NIH definition. Type C will be those patients with hyperandrogenism and polycystic ovaries, and sometimes we refer to them as ovulatory PCOS patients. And lastly, the type D are those with chronic anovulation and polycystic ovaries or the non-hyperandrogenic phenotype. Now, let's take a closer look at the many phases of PCOS. Again, the type A are those patients with all 3 criteria, and we call this the classic PCOS phenotype. Type B are those patients with hyperandrogenism and irregular menses. And type C, those patients with hyperandrogenism and polycystic ovaries, which we sometimes refer to as ovulatory PCOS patients. And lastly, we have type D, patients with irregular menses and polycystic ovaries, which we sometimes refer to as the non-hyperandrogenic phenotype. Now, what are the characteristic endocrine findings in PCOS? Characteristic endocrinologic features include abnormal gonadotropin secretion caused by increased GnRH pulse amplitude and increased pituitary sensitivity to GnRH. These abnormalities result in tonically elevated LH levels in approximately two-thirds of women with PCOS. And women with PCOS who are more obese usually are found to have normal LH levels, and those non-obese or thin usually have elevated LH levels. The high tonic levels of LH, which are often referred to as inappropriate gonadotropin secretion, are due to elevated androgen and unbound estradiol or hypothalamic pituitary functional abnormalities related to neurotransmitters such as dopamine. Because FSH levels in women with PCOS are normal or low, an elevated LH-FSH ratio has been used to diagnose the PCOS patients in the past. However, only 70% of women with a clinical diagnosis of PCOS actually have elevated LH or an elevated LH-FSH ratio which is greater than 3. An elevated LH level or an elevated LH-FSH ratio is neither specific for nor required for the diagnosis of PCOS, and therefore, this measurement should not be used as diagnostic tools. In addition to increased levels of circulatory androgens, women with PCOS have increased levels of biologically active estradiol, meaning these are estradiol which are non-sex hormone binding globulin bound. Okay, and although total circulating levels of estradiol are not increased. The increased amount of non-SHBG bound estradiol is caused by a decrease in SHBG levels, which is brought about by the increased levels of androgen and obesity. Estrone is also increased because of the increased peripheral or adipose conversion of androgen. The tonically increased levels of biologically active estradiol may stimulate increased GnRH pulsatility and produce tonically elevated LH levels and anovulation. The low SHBG level increases the biologically active fractions of androgens in the circulation. Now, this relative hyperestrogenism, meaning there's elevated levels of estrone and non-SHBG bound estradiol, which is often unopposed by progesterone because of anovulation, increases the risk of endometrial hyperplasia or malignancy. Androgens from a variety of sources are also elevated in women with PCOS, and this includes testosterone, androstenedione, and DHEAS. The presence or absence of hirsutism depends on whether these androgens are converted peripherally by 5-alpha reductase enzyme to the more potent form of androgen, which is dihydrotestosterone. And the levels of dihydrotestosterone is reflected by increased circulating levels of 3-alpha androstenediol glucuronide. Women with PCOS who are not hirsute have elevated circulatory levels of testosterone, DHEAS, or both, but not 3-alpha diol G. Approximately 20 to 30% of women with PCOS also have mildly elevated levels of prolactin, possibly because of increased pulsatility of GnRH and tonic stimulation from unopposed estrogen. Now we go to the pathophysiology of PCOS. Genetics and environment both play a significant role in the development of PCOS, and there's actually genome-wide association studies that have determined certain susceptibility genes for PCOS, and this include loci at 2p16.3, 2p21, and 9q33.3 involving the LH human chorionic gonadotropin receptor, a thyroid adenoma locus, and DENND1A. There are actually three major pathophysiological pathways that have been described in the pathophysiology of PCOS, and this include these three. In the following slides, we will discuss each of these. So let's first talk about disordered gonadotropin release and excess androgen release. Hypersecretion of LH can lead to an increase in androgen production by the ovarian theca cells. This is thought to be due to increased gonadotropin releasing hormone pulse frequency, this one, resulting in increased frequency in pulsatile secretion of LH and increased levels of LH relative to FSH. Now, the increased LH-FSH ratio, along with some ovarian resistance to FSH, results in excess production of androgens from the theca cells in ovarian follicles, leading to impaired follicular development. The next pathophysiologic mechanism is ovulatory dysfunction. Now, unlike the ovarian follicular development in healthy women, in PCOS cases, follicle growth is disrupted primarily because of ovarian hyperandrogenism, hyperinsulinemia from insulin resistance, and intra-ovarian paracrine signaling. Hyperinsulinemia impairs follicle growth by amplifying LH-stimulated and insulin-like growth factor 1 stimulated androgen production. Hyperinsulinemia also elevates serum free testosterone levels through decreased hepatic SHBG production and enhances serum IGF-1 bioactivity through suppression of IGF binding protein production. Insulin excess also promotes premature follicle luteinization through enhanced FSH-induced granulosa cell differentiation, which arrests granulosa cell proliferation and subsequent follicle growth. Overproduction of anti-Mullerian hormone by the granulosa cells of ovarian follicles in PCOS patients also appears to antagonize FSH action in small PCOS follicles. The third pathophysiological mechanism is insulin resistance. Now, some degree of insulin resistance occurs in most women with PCOS, even those women with normal weight. Insulin and insulin-like growth factor 1 enhance ovarian androgen production by potentiating the stimulatory action of LH on ovarian androstenedione and testosterone secretion. High levels of insulin bind to the receptor for IGF-1 because of the significant homology of the IGF-1 receptor with the insulin receptor. The granulosa cells also produce IGF-1 and IGF binding proteins. Now, this local production of IGF-1 and IGF binding proteins may result in paracrine control and enhancement of LH stimulation and production of androgens by the theca cells in women with PCOS. Now, since IGF binding proteins are lower in women with PCOS, this one, there is increased bioavailable IGF-1, which increases the stimulation of the theca cells in combination with LH to produce higher levels of androgen production. Elevated insulin levels as well as androgen actually stimulate adipocyte production of adipokines or adipose cytokines, which interfere with the metabolism and breakdown of adipose tissue and further enhance insulin resistance. Insulin resistance in PCOS is primarily characterized by an insulin resistance in peripheral tissues, manifests primarily in muscle and adipose, and minimally at the level of the ovary or adrenal. The cause of insulin resistance in PCOS is actually unknown. It is not caused by insulin receptor defects, but by signaling abnormalities secondary to genetic factors. Most women with PCOS will be found to have euglycemia with peripheral insulin resistance. In more severe cases, there is also evidence of beta cell secretory dysfunction, which increases the risk for type 2 diabetes. It is also recommended that testing should be directed at ruling out diabetes and glucose intolerance among patients with PCOS rather than establishing IR. Now, how do we do this? So, the most recommended will be using the oral glucose tolerance test or the 75 grams OGTT. An alternative would be to use hemoglobin A1C. Now, values greater than 5.8 suggest prediabetes and values greater than 6% suggest frank diabetes. Fasting glucose levels are a poor predictor of diabetes in PCOS, and therefore this is not recommended as a screening tool for diabetes mellitus or glucose intolerance. It can be argued that women who are overweight or obese with PCOS have insulin resistance, and it is not necessary to confirm it. Using fasting glucose and insulin measurements and calculating the quantitative insulin sensitivity check index or quickie or homeostasis model assessment of insulin resistance or HOMA-IR have been useful and correlate well with the more invasive techniques. A physical examination finding of acanthosis nigricans actually signify insulin resistance, and this is present in at least 50% of women with PCOS, especially those who are obese and hyperandrogenic. These are actually velvety hyperpigmented areas usually found in the nape of the neck, the axilla, and the vulvar regions. There's another syndrome that is associated with acanthosis nigricans, and this is the Hare-Ann syndrome, which stands for hyperandrogenism, insulin resistance, and acanthosis nigricans. And this is a specific disorder that is associated with insulin receptor antibodies and presents with very high insulin levels and severe IR. It is distinct from the common findings of most women with PCOS. This is a very nice and simplified diagram of the pathophysiology of PCOS. It kind of like summarizes all the detailed pathologic mechanisms that we have already discussed a few slides back. Now, what is touted as the central pathophysiology of PCOS is still insulin resistance. And with insulin resistance, you have the resulting hyperinsulinemia, high levels of insulin in the bloodstream, will stimulate the ovary to produce excessive levels of androgen. And this hyperandrogenic milieu will actually disrupt or prevent follicular growth and development. And thereby, you have the anovulatory pattern or the anovulatory pattern of bleeding that is seen among patients with PCOS, and consequently, infertility or subfertility. High levels of androgen also manifest as acne, seborrhea, hirsutism, and alopecia. Okay, so the excess levels of androgen are also converted to estradiol. Also, part of the pathophysiologic mechanism will be high LH levels and high LH-FSH ratio, which again stimulates the ovary to produce high levels of androgen. Now we move on to discussing the consequences of polycystic ovary syndrome. Now we see here the full spectrum of the consequences of PCOS from when the woman is of reproductive age to an older age. Women of reproductive age usually have or experience hirsutism, menstrual disorders, infertility, and disorders in sexual health. When they age, then the consequences will be metabolic diseases such as diabetes, cancer, cardiovascular disease, and decreased quality of life. Let us first talk about weight gain or obesity and metabolic syndrome. Weight gain as women age is a major predictor of abnormal metabolic findings and the emergence of cardiovascular disease risks. All the symptoms of PCOS are worse with increasing body weight. There is increased abdominal and visceral fat in women with PCOS, and this has been correlated well with IR and metabolic dysfunction. Therefore, lifestyle management has to be a priority for women with PCOS and must be maintained lifelong. Lifestyle management should be the first line management in all patients with PCOS. The diagnosis of metabolic syndrome is made using the Adult Treatment Panel 3 criteria, and the patient has to fulfill 3 out of the 5 criteria. And the criteria include waist circumference more than 88 centimeters, HDL of less than 50 milligrams per deciliter, triglycerides of more than or equal to 150 milligrams per deciliter, BP of more than or equal to 130/85, and a fasting blood sugar of more than or equal to 110 milligrams per deciliter. Next consequence would be the formation of diabetes. Type 2 diabetes mellitus is more prevalent or 2 to 3 times higher among women with PCOS. And this is driven mainly by insulin resistance, which in turn is worsened by overweight status and menstrual irregularity. In women with impaired glucose tolerance, the conversion to frank diabetes is as high as 54%. Thus, it is extremely important to screen for diabetes in the overweight population with PCOS. And this is best done, as I've already mentioned a few slides back, using an oral glucose tolerance test, specifically the 75 grams OGTT. The third consequence of PCOS is quality of life issues. Poor quality of life among women with PCOS is most likely related to their burden of being overweight or obese, having irregular cycles and decreased fertility, and having skin concerns such as acne and hirsutism. Depression and anxiety disorder may also be present among women with PCOS seeking care and being frustrated with various treatments. Another consequence of PCOS is the development of cardiovascular disease. Women with PCOS have characteristic lipid and lipoprotein abnormalities that tend to increase cardiovascular risk, and data have largely been obtained from women with more classic features of PCOS, particularly those with obesity. Now, in this table here, we see here that the traditional risk factors are obesity, insulin resistance, dyslipidemia, abnormal homocysteine, C-reactive protein, plasminogen activator inhibitor 1, increase in inflammatory adipocytokines such as TNF-alpha, decrease in adiponectin, higher prevalence of diabetes and hypertension. Women with the milder phenotypes diagnosed using the Rotterdam criteria have actually fewer cardiovascular risk factors. Now, unless a woman with PCOS has classic features of PCOS and has diabetes and obesity, there's actually no evidence for increased CV morbidity and mortality among women with PCOS. Now, as you can see here in this table on your left, the risk for cardiovascular disease actually is dependent on the phenotype of PCOS. So those type B and type A PCOS patients actually have the highest risk of cardiovascular disease development. The next consequence would be cancer, particularly endometrial and ovarian cancer. Now, the risk for all cancers increases with aging. However, with endometrial cancer, this can begin at a younger age because of long-term anovulation, obesity, unopposed estrogen stimulation of the endometrium, and possibly comorbidities such as diabetes and hypertension. Thankfully, breast cancer does not seem to be increased in women with PCOS. The level of risk for endometrial and ovarian cancer can be brought down to a normal rate with the use of oral contraceptives. Metformin, which may also be used for women with PCOS, has inhibitory effects on various cancers, and the data are strongest for endometrial and breast cancer. Now, this is a very nice summary of the spectrum of consequences of PCOS, no, from the young age up to the older age of the woman. So in the younger age, we have infertility. Now, as she grows older, she is now maybe stricken with those cancers and metabolic diseases such as diabetes and hypertension. Lastly, we talk about the treatment of PCOS. The treatment of women with PCOS should be directed at the specific complaint. And these concerns fall into three main categories: androgen excess and symptoms of hyperandrogenism, irregular bleeding and the risk of endometrial disease as a result of unopposed estrogen stimulation from anovulation, and fertility concerns and subfertility, mostly because of anovulation. Regardless of the complaint, lifestyle management is an extremely important component of any treatment regimen, and it should be the first line in managing any case of PCOS. Although therapy for women with PCOS should be directed at the woman's specific complaint, improvement of lifestyle variables, including weight reduction and fitness, should be the mainstay of all treatments. Now, with regard to androgen excess, we usually treat this using oral contraceptive pills with estrogen and an anti-androgenic progestin, such as cyproterone acetate. Or we can also treat androgen excess using anti-androgens such as spironolactone or finasteride. For irregular bleeding, they should be directed at supplying the missing progesterone in anovulatory women. This potentially can lead to endometrial hyperplasia or malignancy if not treated. Women who are overweight and older are a higher risk group, and endometrial biopsy may be indicated in some cases. Oral contraceptives are the most logical and effective treatment, particularly if it is known that they reduce the risk of endometrial cancer. OCs may also be indicated for the treatment of symptoms of androgen excess. Progestogen therapy alone may be used at 2 to 3 month intervals to shed the endometrium in chronically anovulatory women. An example of progestogen therapy may be in the form of medroxyprogesterone acetate, norethindrone acetate, or dydrogesterone. Now, for subfertility, we can do ovulation induction using or fertility pills. But before starting treatment, it is necessary to normalize overt abnormalities in glucose tolerance and to encourage weight loss for overweight and obese women. Ovulation induction may be accomplished by a variety of agents, and this include clomiphene, letrozole, gonadotropins, pulsatile GnRH, and ovarian diathermy or drilling. IVF may be indicated in difficult to manage cases or if other infertility factors are present. Letrozole, in recent studies, is now the first line for ovulation induction for women with PCOS. In the past, it used to be clomiphene citrate. Now it's letrozole. Low-dose gonadotropin therapy is highly effective as a second-line treatment, especially patients with failure for oral agents and for the occasional patient who may have transitory low estrogen status. Ovarian drilling or diathermy is also a reasonable second-line therapy, particularly in clomiphene failures and when gonadotropin therapy is difficult to administer. Now, for women who fail to conceive with ovulation induction over 6 cycles and in those with other infertility factors, then IVF would be the next logical step. The only caveat to IVF treatment in women with PCOS is the higher than normal risk of OHSS, or what we call the ovarian hyperstimulation syndrome. And this should always be kept in mind when you treat women with PCOS with significant dose adjustments in the treatment regimen. Now, for metabolic and weight concerns, as I've already mentioned, several times in the past few slides, lifestyle management should be the key management strategy or the first line in managing PCOS patients. And when we say lifestyle management, this should always include exercise and diet. Metabolic syndrome is usually treated by a combination of diet and metformin, and this will reduce insulin resistance and improve metabolic parameters. Bariatric surgery is actually an option for morbidly obese women or for women who are of a very high BMI and have failed in the traditional exercise and diet regimen. Now, this is a very nice summary, showing to us the different treatment regimens for women with PCOS according to the patient's concern or chief complaint. So if the concern is infertility, then the treatment options include letrozole, clomiphene, with or without metformin, and we can also offer gonadotropins or ovarian drilling as a second line. For skin manifestations such as acne, hirsutism, we can offer oral contraceptive plus an anti-androgen, or we can also give GnRH agonist. For patients with abnormal uterine bleeding or irregular menses, then we can give or offer cyclic progestogen or oral contraceptives. And for women with weight and metabolic concerns, of course, as I've already mentioned, first line is diet or lifestyle management. And we can also start her on metformin. Okay, so that's the end of our lecture. So in summary, we have talked about the diagnosis of PCOS using the ESHRE, criteria. We also talked about the different pathophysiological mechanisms of PCOS with insulin resistance as the central mechanism or central pathophysiology, the consequences of PCOS such as diabetes and cardiovascular disease, and of course, the different treatment regimens that we can offer our PCOS patients. That's it for this lecture, and thank you for your kind attention.